So I'm Brianne. This is the presentation day. Pan of my crowd. We've got 9 in attendance. Let's go ahead and bring this back. All right. Good afternoon, everybody. Welcome to the presentation. Are you ready to talk about some thyroid nodules today? Because I know I am. So while this is not going to be the most exciting topic, the technology that we're going to discuss today hopefully will make up for that. So let's get started. So of course, in a presentation, there's always objectives. So today, by the time we're done with the presentation, we're going to hopefully be able to associate the incidence of thyroid nodules and malignancy risk, recognize the pitfalls of current cytology findings, distinguish limitations of the TI-RADS reporting system, compare the significance of standard sonographic characteristics of nodules, and discuss ultrasound elastography and its effectiveness. So, what are thyroid nodules? Thyroid nodules are the most common endocrine tumor within the thyroid gland. On average, clinically palpable nodules are found in about 5% of the adult population. Most nodules are so small, typically under a centimeter, and they're discovered incidentally on imaging studies such as CT or MRI. Finding incidental nodules on imaging has become increased in incidence due to the increased use of high-resolution studies such as CT or MRI. Most diagnosed nodules are benign, with less than 5% of them actually being thyroid cancer. The incidence of thyroid cancer has been rapidly increasing, and recent studies show that the incidence has been increasing more rapidly than any other cancer type. Now, what is causing the increase? It's thought to believe that the increase is occurring because of some of the reasons I have listed up here. The increased use of medical radiation, iodine intake, obviously we all have high salt diets, obesity, genetics, insulin resistance, and the increased use of inorganic phosphates. Many chronic diseases, including cancer, have been proposed to be associated with high phosphorus intake. This derives from growing consumption of highly processed foods, especially restaurant and fast foods, that contain such ingredients. Some of these items cause cancer by creating cellular changes in the thyroid gland. And while thyroid cancer doesn't typically lead to death, the increase of the incidence is still concerning to researchers. Typical thyroid nodule management, or if they're suspecting there's a thyroid nodule, usually begins with a clinical assessment by the patient's physician, which then leads to having thyroid labs drawn, checking the TSH level in the blood, an ultrasound evaluation, which when that is abnormal, it can lead to a fine needle aspiration or biopsy recommendation. Records show that more than 450,000 thyroid biopsies and more than 120,000 thyroid surgeries are performed annually in the United States, with only less than 5% of them actually being diagnosed with cancer. So with that said, the amount of invasive procedures being performed is staggering and most likely unnecessary. Fine needle aspiration cytology typically provides enough information to classify 72% of thyroid nodules as benign, while approximately 5% of them are malignant. To categorize the cytology findings, the 6-tiered Bethesda system is used, as you can see up here on the slide. And this is the system used for cytopathology, and it has become the standard for reporting fine needle aspiration results of thyroid surgery biopsies. Under this system, some thyroid nodules fall into the indeterminate category, which is considered the 3rd tier, which is the top middle slide. And this means that they have an intermediate risk of being cancer. Among that intermediate category, atypia of uncertain significance and follicular lesions of uncertain significance carry a 5 to 15% chance of malignancy, while follicular neoplasms that fall in this category carry a 15 to 39% chance of malignancy. So what does all this mean for the patient? The current trend to treat nodules for indeterminate cytology results is for the patient to undergo surgery to either remove partial or complete, the partial, part of, or the complete thyroid gland for a final pathological diagnosis. Of this population, approximately 3/4 of the nodules removed end up being benign. The need for patients to undergo surgery has unfortunately become what they call a necessary evil to get a final diagnosis. Based on this evidence, the need to improve preoperative malignancy risk in patients with indeterminate findings on fine needle aspirations has caught the attention of researchers across the globe. So, what is ultrasound's role in all of this? How can it help with the problem? Well, we all know, everybody's very familiar with ultrasound in this room. Ultrasound's used on pretty much any part of the body. They use it on every part of the body to determine, pathology, masses, just to help diagnose any possible abnormality. Ultrasound features that we assess include the echotexture of the tissue, size of any area that's found, vascular involvement, and also growth patterns in order to assess the risk of concern. High-resolution B-mode ultrasound, which is your standard grayscale ultrasound, is preferred for thyroid evaluation over any other imaging modality. Ultrasound can usually tell cystic from solid components on any area that it discovers, which does set it apart from other modes of imaging. Ultrasound evaluation of the thyroid is part of the standard of care for suspected nodules, as we discussed previously. So, when I talk about ultrasound characteristics, this is a list of some of the things that we look for in this example if we were to find nodules or any kind of pathology in the thyroid. With ultrasound, we look for the location of the area. Is it located next to vessels, other important organs? That's a very important thing to know. The form of the area. Is it round? Is it square? Is it triangular? Any size or shape we can tell with ultrasound. Size being the next one. When you're talking about thyroid nodules, any nodule that's under a centimeter is usually not biopsied right away unless it has certain characteristics, which we'll talk about that as well. Typically, once a nodule is 1 centimeter or above, it's more likely to be recommended for immediate sampling. Echotexture. In this picture, this is the entire thyroid gland. You're looking at, if you were to look at an axial or transverse of the neck. So this is your esophagus and trachea here, the right lobe of the thyroid, the isthmus, and the left lobe. Normal thyroid tissue has this brighter, what we call echogenic texture. When we're looking at echotexture, is it a nice, smooth, uniform texture? Does it have a mottled appearance? When you find nodules, which I have some examples, you'll see typically circular or obviously abnormal areas within the thyroid. These are all things that we assess with ultrasound. Calcifications. And anybody familiar with breast imaging knows the calcifications, depending on how many clustered or grouped together, knows that that could be good or bad. So that is also something that ultrasound can typically pick up. Echo halo effect. This is also something that kind of crosses over into breast imaging. When diseased tissue meets healthy tissue in the body, it can create an echogenic rim around the mass or lesion. So this is something that, when seen, that is highly suggestive for sampling. Boundaries and edges of the lesion. When you find lesions anywhere in the body with ultrasound, we're able to scan completely through the area. Is it nice and round? Does it have finger-like projections, lobular edges, smooth edges, well-defined borders? And of course, the most important aspect of ultrasound is that we can detect if there's a presence of internal blood flow in the mass. Most internal blood flow within a mass can mean that the area is demanding more blood flow, which is typically seen with malignant lesions or cancerous lesions within the body. It's a tiny plan, but there's a lot to look at. So, with this list of characteristics that we just went over, the amount of characteristics that you find with ultrasound also can lead to, okay, this is more of a benign, not worrisome, or something that we need to take care of with sampling immediately. So the examples that I have up here, on this side, this is the thyroid again, just a different projection. So the brighter tissues, the thyroid gland, kind of obvious there's something here that probably shouldn't be there. So this is more of a benign appearing, not as worrisome lesion found in the thyroid. It's got well-defined borders. It is a little bit darker, which is when we were talking about the echo texture, you can tell that it's a lot darker than the rest of the tissue. That is concerning. The fact that it has little echoes inside means it's probably that it's what we would call solid appearing. Not 100% sure it's solid. It could be a bloody cyst. It's got some brightness behind it, which does make you think that this could be some fluid, because this is a physics characteristic of ultrasound fluid lesions. So this is something that it probably might follow, or because it is a little bit bigger, they might sample, but you can tell this. Now when I come to the other side, where you have multiple sonographic characteristics that are worrisome. This is the thyroid gland. Notice from the get-go, it's very mottled, looks nothing like this nice bright tissue over here. I don't know if you guys can see there's a blue arrow and a red arrow. Those are pointing to tiny microcalcifications within that thyroid gland. There's actually a nodule sitting here. It's kind of hard to see. So this one has what they would call ill-defined borders. It would be a lot harder to measure for the sonographer. And it's got this kind of cluster of calcifications in here with some shadowing, which those are all red flags for possible malignant or abnormal lesions. So this is what we would consider more of a single characteristic. That's definitely multiple characteristics that are common. Typically, no single feature, ultrasound feature alone can provide enough accuracy in order to diagnose just from a picture, same as most modalities. When multiple characteristics or features are present within the nodule, the specificity of malignancy goes up, but the sensitivity of imaging goes down, because as you can see, it's a little harder to evaluate that thyroid tissue from this one. So for this slide, we're going to talk about TIRAD. I don't know if anybody ever heard of TIRADs? BIRADs, right? All right. So TIRADs is actually the thyroid version of the BIRAD scale. BIRADs being the classification system for breast imaging. So this is the thyroid imaging reporting and classification system. To simplify descriptions of multiple sonographic findings in relation to the concern of malignancy, the TIRAD system was created in 2009 by E. Horvath and Associates to help establish risk groups and decide when FNAs should be recommended. The TIRAD system was created on the foundation of the BIRADS breast reporting system, which that was developed by the American College of Radiology for breast lesions that were found on mammography and ultrasound. So on this slide, I have an example of the TIRADS classification chart. And again, very parallel with the BIRADS. So if you were to look at an ultrasound study, normal thyroid, it's a TIRADS 1. If you get into a thyroid that might have some thyroiditis, which is where we're going to get that mottled appearance, maybe one or two little calcifications kind of just anywhere in the gland. Might find a simple cyst in the thyroid. These are all things that would categorize it as a TIRADS 2. When you get up to TIRADS 3, these are your areas, probably nodules like the nice round one that we looked at. If that one was probably a little bit smaller, more than likely it would fall in the TIRADS 3 category, which means they're probably going to send that patient back in 6 months to a year to get evaluated. If it's a newer nodule, they're probably going to come back in 6 months. If it's something we've been watching for a while, our patients typically come back annually. Once you get past the third level, 4A, 4B, and 5, those are all areas that are most likely going to get recommended for fine needle aspiration or even a core sampling, depending on the positioning. All right. So as with anything, TIRADS has its limitations. TIRADS was created to hopefully be the global standard of nodule classification. It has been limited and questioned in application for feasibility due to being too subjective. It's all in the eyes of the beholder. What one person sees as a normal nodule, the other person might not see it that way. researchers found that different geographical and patient populations all came up with their own version of TI-RADS, and they each used varying levels of nodule characteristics as reference points. This is why there is still, as of today, no universally recognized TI-RADS system. Now, the ACR has been working on developing its own system to hopefully kind of catch speed and everybody start using, but they have decided to try to base theirs off of something called K-TI-RADS. K-TI-RADS is actually the version created by the Korean Society of Thyroid Radiology. The Korean version uses a flowchart guided system, and as the ultrasound, which is a little bit different from our TI-RADS, it was more just a straight up, this one has, okay, flowchart, if it's got this, yes, you do this, that type of flowchart. So, as the ultrasound community continues to debate on a universal TI-RADS system, another crucial area has entered the arena of thyroid imaging known as ultrasound elastography. This is where the pretty color pictures come in. So ultrasound elastography is a technique that has had reported success in areas such as breast lesion evaluation, prostate cancers, and also liver fibrosis. Historically, most cancerous tumors manifest as a hardened, stiff lesion that is not always palpable. Ultrasound elastography assesses the lesion stiffness by evaluating tissue distortion and elasticity in response to external stress. This feature is an added expense when purchasing ultrasound units and also requires additional education for the sonographer and the radiologist who's dictating the exam. This is probably most likely why it's not routinely being used in all labs that scan thyroids. We have one machine, I think, that can do elastography, because it is expensive. So how does elastography work? So during the real-time ultrasound assessment, which would be your typical grayscale imaging, and again on this image we have, this is just one lobe of the thyroid. There's where the isthmus is crossing over, you have your trachea and esophagus. While you're scanning that part, you push a button and it activates the feature. This adds no extra time to the scan and no added discomfort to the patient. As external stress is applied, or depending on which type you have, some form of stress is applied, the stiffness of the nodule appears via a color scale on the opposite image. So in this example, you see a color scale here in the middle. The red, orange, yellow tissues are your softer, more normal tissues. Green's kind of your in the middle. And down here, you notice that as it comes down to the darker blue and purple, that's your stiffer tissue. So this is the same identical image. Activate the feature, put a little bit of stress just by pushing. And what that does is it puts strain on the tissues in there. Now, on standard ultrasound, this is already kind of an abnormal nodule. It's got cystic components, but these little white lines are some septations. Could maybe fall into a 3 or a 4A, probably on the TI-RADS scale, depending on who's reading it as to whether they would recommend that for sampling. What this does, it just gives one little boost, because when they put pressure, notice that area is mostly all dark blue and purple, which on the scale, that's harder tissue, that's not good. So by turning on this feature, what you've done now is you've pretty much taken that indecisive radiologist and it's given him a little bit more information to help determine if he wants to sample this area. All right, so there are multiple types of elastography available in the market. The two main actual types are quantitative or qualitative. Both give you the same amount of tissue or the same amount of information the same way. The only difference between all of these listed is how you apply the stress to the area. For an example, the shear wave elastography on the list, right there in the middle, it uses the acoustic pulses that actually are just produced by the ultrasound transducer. That's the form of stress. So you're not having to push on anything, you just turn on the button, the natural pulses of the ultrasound create the color pattern that you're looking for. The one that I think is interesting is the carotid elastography, and that actually just uses the natural pulsation of the carotid artery to apply pressure to this area to get the color that you want to see, to estimate joint stiffness. The only difference, the reason why there's so many is because depending on what brand or model of ultrasound unit, some of them, they might be very similar, maybe just named differently, or might have one or two little features, because I believe the last one, the Explorer, that's actually named kind of because that's the manufacturer. So, the effectiveness of elastography. So upon review of all the available literature, ranging from 2013 to the present, one can definitely see the progression of the effectiveness of ultrasound elastography for risk assessment of thyroid nodules. Now, most conclusions in the literature that I reviewed stated that ultrasound elastography was effective in determining the elasticity of the nodule and the risk of malignancy to some degree. The problem with each study was that after successful results, the recommendation for additional research based on the limitations left me and the readers wondering what the actual value was of each study. Some studies only tested the use of either type of quantitative or qualitative ultrasound elastography without comparison to each other. Others had limited sample sizes or limitations in the type of nodules that they tested. In the more recent study by Rago et al. In 2017, it was published that they did have success by using both types of elastography to study the degree of elasticity with cytologically proven malignancies, even including those previously listed as indeterminate. So how do you fix that? Combine forces. Combining the use of elastography with the TIRADS reporting system, as published in 2015 by Stone et al., combined the efforts of elastography and TIRADS to test that predictive value of the nodules in question. To test the strategy, Stone and Associates added quantitative strain elastography as a sixth parameter on the TIRADS imaging system. Unfortunately, one of the listed limits of the study were that not all the nodules in question underwent an FNA sampling afterwards, so it still kind of left them as to they tested it, but was it really still a cancerous nodule, benign? So there were some limitations there. But even with this limitation, the conclusion of the study was that by combining the two methods and putting the two pieces of the puzzle together, it did add to the diagnostic power of the risk stratification nodule, that nodules for the ones that did undergo fine needle aspiration analysis. So to come up with an actual conclusion, we need to find a better way to test. Based on all the limitations that were given by the authors in the reports that I read, some of the limitations being small sample sizes, variations in the TIRAD system as we talked about, variations in the elastography systems available. It seems that in order to get a thorough study, a few things should probably be added. One could start by listing all the previous limitations of every study published to make sure that everything is addressed, that you cover all the avenues listed by the previous researchers. And also using all available tools at the time of study. Gather every every TIRADS version that you can find, a lot of T's, and every version of ultrasound elastography. Line your machines up, test that nodule, every single type of machine. It's pretty, it's going to be a pretty big undertaking, so I can see why a lot of people probably haven't done that yet. Lastly, a larger sample size should also be utilized to cover a large amount of the population and also the various nodules that could be found. So, in conclusion, even as I speak, there are new and improved ways of attempting to differentiate indeterminate thyroid nodules being tested. Most of the ones that I have encountered still have some aspect of interventional or surgical component. Here at our hospital, we also we do some sampling on our normal fine needle aspirations, and we do a separate container for something called a FIRMA, where if it's an indeterminate nodule, our hospital pathologists do send this on, but again, it still has that interventional component. Ultrasound remains the one diagnostic tool that does not require such means to gather data needed to assess the patient and plan for the management of the nodule in question. As elastography becomes more mainstream, it may be widely accepted and used among those in the medical imaging community. I thank you all for spending your afternoon with me, and I do welcome any questions that you might have on this topic. References, it's a lot of reading, a lot of highlights. Questions, anybody? Jen?
Okay. So when you were talking about elastography, currently do we use that here on any? You said we have one machine that we use.
We do have one machine I know of that the features on, but we don't use
We
it.
want to use it for any, not even just thyroids, anything across the board.
Because you have to have the additional education and training goes with it, and the radiologists that I'm aware of don't have that training either.
So you mentioned, at one point in your presentation, you mentioned it was with the pressure. But
Yes.
some of the machines do it, so you could probably buy some machines that it depends on the tech, right?
Yeah, there are some that rely on the difference in the elastography types. Some rely on manual pressure by the technologist. They lightly push on the area. I've actually used that for breast imaging in other places that I've been. But some of them, like we talked about, the carotid or the strain, I believe, or shear wave, uses just natural pulsations of either the carotid or the ultrasound transducer. So it would just depend on your preference when you're looking for machines or programs, your preference, or maybe just what that vendor offers through their equipment.
So are there other tests that you could use it on? You mentioned for nodules here, but what other anatomy or situations would you use that in that could be diagnosed something different? Maybe?
For elastography, it's used for breast lesions. I'm not sure if our breast units have it, they might, but for the same reason. If there's that breast lesion in question, which breast lesions tend to be kind of complex and very, you don't know what to do with them. Spend a lot of time debating that, excuse me. So again, that would help give the radiologist that one little additional piece of information that might lead them one way or the other. It's used for pancreatic tumors. I actually just read recently the prostate gland. Prostate imaging is done rectally. It's uncomfortable for the patient. A lot of times you don't get really good pictures. Either a lot of men go vasovagal during a procedure. It's just a very hard organ to evaluate. So I've seen where institutions are using the elastography to test the stiffness of the prostate gland. And if it tends to be stiffer, then they might be more likely to remove or treat it.
So it's typically used for diagnosis of malignancy on like a nodule that's found, not necessarily any other diagnosis that could be.
Yes, they actually use it for liver cirrhosis. Just if your liver with cirrhosis patients, your liver is stiffer because it's a fibrous tissue. And I actually know somebody, I have somebody in my family that gets it done at her doctor's office, her GI specialist. They actually do the elastography on her liver to stage her cirrhosis. So, pretty interesting. A lot of uses. Any other questions? Okay.
The TIRADS, that's something new. I can't say that I've seen that being done here before. Have you seen it done on any of our radiologists currently using that, any of those systems that you spoke about?
No, any place that I've been, I've never seen anybody use the actual TIRAD scale. We used more of the size evaluation, kind of went by the size of the nodule and more of like whether it had multiple characteristics. So in a way it was TIRADS, but it's not like they use that actual chart, and we didn't put it in the reports like we do with breast imaging.
So do you see it at one point becoming more like like the MQSA standards where you have to report on it?
Yeah, that's what the ACR is trying to get in place. Yes.
So are the TIRADS, are they based at the point of the scan for the nodules or the pathology?
The TIRADS, that goes with the radiologist dictation. Okay. Yep, that would be a radiologist call. Whoever's reading the thyroid imaging. Any other questions? Okay, well, this concludes our presentation. Thank you.
Yeah, very.
That was interesting. Yeah.